So good evening. This is another AONM webinar. Thank you very, very much for joining. We're delighted to have a team here today with Professor Jack Lambert and Professor Leona Gilbert, Dr. Minha Rajput-Ray, and Mr. Kunal Garg. Gordana Avramovic has got a little bit delayed. She'll hopefully be joining us very soon. So they're going to be speaking about advances in CD cell, Lyme, and co-infection research, insights from recent studies. If you have questions, please pop them into the chat or the Q&A. They'll be speaking for about 40-45 minutes, and then we'll have time for a roundtable discussion at the end. So thank you very much again, everyone. They'll be introducing themselves, by the way, as we go through.
Thank you, Jillian. So I'm going to start here and share my screen and then share the PowerPoint presentation that we have prepared. And yes, I really want to thank you for spending your time with us to listen to our talk about what's been going on with the Irish patient database that we have collaboratively worked on. And this is kind of like the comprehensive analysis of the clinical biomarkers, pain management, and economic impact in the Irish patient cohort with Lyme disease and tick-borne diseases. And I'm Leona Gilbert. I'm the CEO of Tested, and we do research. We developed medical devices, and I'm really proud to say that I'm a member of this collaboration and a part of a member of doing this research. I would like to have Jack, if that's okay, to present himself.
Okay, so hi, my name is Dr. Jack Lambert, and I'm an infectious disease specialist in Ireland, and I see primarily patients with missed Lyme diagnosis or late Lyme diagnosis or partially treated Lyme diagnosis, and I've been treating people for years, and there's 29 infectious disease specialists in Ireland, and I'm the only one that will give people longer course antibiotics because my clinical experience is it seems to help a lot of people, number one. And number two, it seems to be a safe option, as long as you do the appropriate monitoring. But anyway, in response to kind of some negative feedback on, from a number of the infectious disease doctors in Ireland and back in 2018, I was advised, start collecting your data, start putting together your database, start kind of cataloging your clinical experience in terms of managing patients. My observation has been that, some patients have more than one infection. Some people benefit from longer course antibiotics, sometimes combination antibiotics. And I would say on average, my data, my clinical experience shows about 70% of people respond to the antibiotics. So there must be a residual bacterial infection or multiple infection that's triggering all of these kind of long-term symptoms of patients whose history is, a likely tick bite and manifestations following that tick bite. So like I said, the database that we put together was 301 patients that we did questionnaires on before and after starting therapy. I did just standard, this was not a research study, so it was my standard clinical blood test, full blood counts, autoantibodies, immunoglobulins, lymphocyte markers, inflammatory markers. These are just standard tests I do in everybody, but we did these tests and we did them in follow-up. And like I said, out of that, kind of advice on kind of keeping track of my records on patients and trying to get the data published, we put together experience on 301 patients treated with longer course antibiotics for Lyme and co-infections, and their clinical responses, and the fact that only 2 out of the whole 301 were unable to tolerate the antibiotics. And I think that's an important message. The message that I hear all the time from my Infectious Disease Society of America, trained doctors, I'm also part of that group, is that Lyme is easy to diagnose, easy to treat, 2 weeks of antibiotics and everybody's cured. Well, that's not the truth. And I think there's a dearth of shortage of things in the literature really supporting an alternative, experience. So that's what, today's presentation and the results from today's presentation is about.
Great. So I'm going to share screen again, and I'm going to now ask actually Kunal, if you could shortly present yourself. Is that all right?
Yeah. Hello, everyone. I'm Kunal Garg. So I'm the Chief Technology Officer at Tested, where we make medical devices, and we are involved in research. And the Irish database was one of those projects. Thank you.
And Minha, if you want to shortly present yourself.
A very good evening and greetings from Dundee. I'm an integrative physician. My background is pain and rheumatology, hence my fellowship, which was in Cambridge. And then, of course, further to that, occupational and disability in London. And I also trained in ecological medicine. Prior to medicine, I trained as a naturopathic physician and as a DO, Doctor of Osteopathic Medicine. So my work is very much looking after patients with pain and chronic disease management, and in a way bridging what we would say conventional medicine with perhaps what we would say out-of-the-box approaches. So delighted to be here with my esteemed colleagues and with yourselves, the delegates.
Great. So I'm going to share screen again, and we're going to start the formal presentation. So to be more specific about the goals and objectives of our presentation, we want to get an appreciation of how important it is to establish a patient database in order not to just publish the work surrounding these patients, but actually to have a more in-depth and more kind of personal understanding of what the patients are going through. Also, the objective is to present our recent findings in published work and unpublished work in the clinical aspects of tick-borne infections, and obviously the effective treatment Jack has had in its protocol. And also then to highlight the importance of immune markers, biomarkers, and in the diagnosing of tick-borne infections. And then lastly, to go over the economic implications of chronic Lyme disease in this cohort and the benefits of consistent diagnosis and treatment. So the presentation is really based on 4 publications here. The first 2 publications, one has been published last year, and the second publication was published this year, and we have 2 for submission. And we have a lot of really good take-home points in regards to these papers, and we're going to kind of focus on really thinking about tick-borne infections holistically, and the treatment protocol that was used to see success in 75% of the patients. Then we're going to really dive into clinical markers and standard laboratory markers and how they can be helpful in actually diagnosing Lyme disease and other tick-borne infections. And then, of course, the 2 last papers that are for submission and just about to be submitted is really kind of correlating biomarkers with pain that we see in these patients before and after antibiotic treatments. And then, of course, we did really an estimate of the prevalence and economic burden related to these chronic Lyme disease patients in Ireland. So with this, please keep in mind, it's because of a patient database that we started, okay, that we were able to come together. And establishment of databases, especially this Irish patient database, allows for streamlined access to patients' histories. It standardizes the format in which the clinicians and researchers can see actually the progress or even any indication of biomarkers or treatment success or failures within the patients. It enables personalized treatment plans, a better way of tracking these plans in these patients, and a faster decision-making. Databases significantly can improve research opportunities, as you can see with these 4 publications, and then hopefully that can lead into medical breakthroughs. So by leveraging data, especially patient data, healthcare providers can predict trends, what they're seeing in these types of patients. They can actually compare and contrast these predictive trends with other patient groups from other countries, let's say, and hopefully come up with strategies to prevent illnesses and overall improve patient care. So the Irish study as a whole cohort, okay, as I mentioned, is a summary of 4 articles. The take-home messages of each of these articles and what we're going to present logically within this presentation is this. The first paper basically correlating the clinical symptoms and treatment outcomes in this cohort. The second paper, we discuss standard laboratory immune markers and also biomarkers to help predict and diagnosing and seeing the outcome in these patients. Then the third manuscript that's, as I mentioned, ready for submission, is actually correlating these biomarkers with pain that we see in these patients before treatment and after treatment. And then lastly, we devise a prevalence and an economic impact burden of these chronic Lyme disease patients in Ireland. So I wanted to actually just stress how important it is to understand the clinical and economical impacts. You think that this may be a no-brainer, but as we know, early diagnosis, early treatment is very critical to prevent the progression of chronic Lyme disease, because we know that chronic Lyme disease, I don't need to tell you, is persistent symptoms that mimic a lot of other conditions, but also are very apparent in these patients, such as pain, fatigue, neurological issues, and it really significantly affects the outcome or the quality of life in these patients. And it is really important to understand the burden of this, the economic burden of tick-borne infections, because it includes direct medical costs and as well as indirect costs due to loss of productivity or long-term healthcare needs. And with this analysis of the economic impact, we were able to suggest actually effective management and treatment protocols that can be utilized to help with these tick-borne infections, and therefore reduce, the cost and improve the overall kind of public health and individual patient health outcomes. So this is why we took kind of this circular kind of objective moving forward. So the first paper, was published last year, and it's titled A Longitudinal Study of a Large Clinical Cohort of Patients with Lyme Disease and Tick-Borne Infections Treated with a Combination of Antibiotics. And again, the take-home message for this paper is that we're looking at the clinical symptoms that were discussed in the survey, as Jack had mentioned, and overall seeing, how well they did with the treatment that Jack prescribed. Okay, so we have Kunal. Are you okay, Kunal?
Yeah. So in order to understand the results, before we dive into it, I think it's important to get an understanding of how the patient immune response is actually seen in this study. So we obviously had a lot of patients, and that is 83% in table 2 on the top left, that responded to Borrelia species alone. However, when you look at the other pathogens that were included in ticklets, for example, we do see patients responding to pathogens other than Borrelia. Although there's a minority of these patients, it does put a point forth that we cannot test only for Lyme disease. And this is further established in table 3, wherein you can see that Borrelia in combination with Babesia, Bartonella, Ehrlichia, and Rickettsia, we see almost 30% of the patients responding to a combination of these pathogens. Whereas apart from Borrelia, we also see patients responding to Babesia and Rickettsia, Babesia, Rickettsia, and Ehrlichia, and so forth. Although again, in minority, we do see patients responding to these other co-infections, essentially. Finally, coming to the table on the bottom left, we finally see a descriptive statistics of what is actually going on when we talk about pain, neurological manifestations, or fatigue in these patients. So at time point T1, we see that the number of patients reporting these symptoms are higher compared to at T2 after the antibiotic treatment when it drops. And we see that from the pair T test, for example, the drop in the number of patients reporting pain, neurological manifestations of fatigue is actually statistically significant, except for fatigue. But the Cohen's interpretation is medium, essentially reiterating that the effect size that we are seeing amongst these patients responding essentially to pain and neurological manifestations is of a medium effect size. So it is statistically relevant. So to get a much better idea of how these patients are responding at different time points, we go to the next slide, wherein on the top you can see a distribution. So in blue, you can see patients responding to symptom rating. So symptom rating refers to how severe the patient symptom is, and it goes from 1 being less severe to 10 being extremely severe. So when the patients walk in this particular database at the Irish Clinic, you can see that the symptom ratings are quite low, and then as we go on with the time points, the symptom rating actually becomes better. So sorry, the symptom rating is the other way. So how well are you? So 1 is poor and 10 is better. Yeah, sorry for mixing that up, because we have many different scales in this database. So at T0, the patients are feeling not so good, but at T2, which is in green, the patients start feeling better. And you can see that the distributions are quite different. At T0 in blue, most of the patients are between 1 and 4. At T1 in orange, most patients are between 3 and 7. And at T2 in green, most patients are between 6 and 10. And so this is a distribution. This is just a visual way to look at it. But if you want to put a probability at it, we come to the chart below. So symptom rating of 5, because it's halfway. If we ask what is the likelihood of seeing a patient, or what is the probability of seeing a patient with symptom rating 5 at T0, the probability is about 90%, which drops to less than about 40% at T1, which further drops to about 30% at T2. So you can see that not only is the distribution different, but the probability of seeing the patient with a particular symptom rating actually falls as and when the patient is longitudinally followed. And now we try to connect why this is happening to based on biomarkers and other aspects that you will see in the remaining slides.
Great. And Jack, if you can go over this slide of your treatment protocol and what you use.
Right. Well, since I see patients clinically, so I make a decision. I usually use combination antibiotics because multiple infections are the rule. I usually try to include antibiotics that penetrate well, deep into the tissues. So antibiotics like azithromycin and rifampicin have a good history of, good penetration into intracellular pathogens. And since these patients are chronically infected, I would say most of the pathogens are in the tissues, not in the blood circulating. But anyway, I make a decision how to treat people based on whether they have allergies, whether they have tolerability, issues with antibiotics previously, but it's usually some combination of cefuroxime or, I now use amoxicillin more because there's a shortage of cefuroxime in UK and Ireland right now, but it's usually a combination of cefuroxime, rifampicin, and one of the doxycyclines like Lyme cycline or azithromycin, because then you're covering Lyme, you're covering Bartonella, and you've got some coverage against the atypical organisms as well, some chlamydia pneumonia, mycoplasma pneumonia, and Anaplasma rickettsia, are covered by the Lyme cycline and by the azithromycin. So these different combinations are just based, having reviewed patients, individualizing treatment for them, treating for Lyme and co-infections. And I usually start off with a 2-month prescription for antibiotics. And then I review patients every 2 to 3 months after, sometimes modify the antibiotics, and sometimes keep them on the same antibiotics. So that really is just a summary of my approach to managing kind of chronic Lyme patients with Borrelia and other co-infections, and individualizing their therapy, based on their tolerability, allergies, and the organisms I think I'm targeting.
Great, thank you. So basically the key findings of this paper and this research is that majority of the patients were infected with Borrelia burgdorferi, 1/3 had co-infections with the other tick-borne pathogens. The common persistent symptoms, statistically speaking, were pain, fatigue, and neurological issues. And in regards to the treatment outcomes, the long-term combination of antibiotics led to symptom resolution in 75% of the patients. So really, it's good to get clinical symptom recorded and also to record the treatment outcomes at different time points to get the statistics that's needed in order to show what is working and maybe what needs to be improved. So as we move on to the next slide, we're now going to talk about actually scrutinizing this cohort for clinical biomarkers. Okay, and obviously this cohort are suffering from Lyme disease and other tick-borne infections. So basically, we're looking at standard laboratory biomarkers and then, of course, immune markers and see if we could actually see anything that's statistically significant. So Kunal, if you want to go over this.
Right. So in the previous paper, you've seen an overview of what antibiotic combinations were used and what form of immune responses were there in these patients, and also the symptom rating. But now we get into the biomarkers, and we had a number of biomarkers, as you can see on the y-axis on the left-hand side. And then on the x-axis on the top, you can see the percentage of patients presenting an abnormal value. So the abnormal value refers to the range which is above or below the accepted range for each of these biomarkers, and we've essentially counted how many patients at time point T0 and at time point T2 have presented abnormal values. So overall, you can see that in some cases, for example, the low CD8 suppressor T cell count, there is really no difference. However, in others, you can see slight difference. So, for example, at the top, low CD3 percentage, there is a difference from T0 to T2, but this was not statistically significant. To narrow down and really study the ones that were statistically significant, we saw a major difference in low CD4 percentage. As you can see that the number of patients that were presenting abnormal values at T0 was much higher compared to T2. Then we go down to low transferrin, high transferrin, and low transferrin saturation. And again, in this case, you can see that the low transferrin, the number of patients presenting abnormal values was less at T0 compared to at T2. So this is an indirect relation, or this is an indirect relationship, which will be very interesting to look at when we correlate it with a certain symptom. And for high transferrin and low transferrin saturation, again, we see that at T0, there are more patients presenting abnormal values compared to T2. So there is a level of normality returning in these patients after the treatment, and we see this difference from T0 to T2. To understand if this overall difference is something that we can also correlate with the type of immune response that is seen in these patients, we see that in the next slide. So in this, on the left-hand side, it's a panel and it has too many dots and lines, but you essentially look at a few things over here. So we have marked T0 time point as a circle and T2 as a triangle, and the different color lines essentially represent the type of immune response we are dealing with. So we have 4 categories of patients over here: the ones that have only responded to the Borrelia antigens, then in orange, the ones that have responded to Borrelia and co-infections, as we previously saw in the previous paper, then in green, the ones that have responded to tick-borne antigens that were other than Borrelia, and then finally the ones that did not have any response, so the negative serology. In most cases, like the low CD3 percentage, you can see that there's not a constant trend, and we know this because in the previous graph, we saw that this was not a statistically significant marker. But for example, low CD4, you can see that irrespective of the immune response the patient demonstrated from T0 to T2, there is a drop. We see a similar trend in figure D for low transferrin. From T0 to T2, there is an increase. High transferrin, there is a decrease. Low transferrin, there is a decrease. And again, high transferrin saturation, there's an increase. So in biomarkers that were statistically significant and they were showing a certain increase or decreasing trend from T0 to T2, we see that irrespective of the type of immune response that these patients were presenting, we see the trend continuing for these biomarkers. So moving to the next slide.
I can take over this. So what was interesting about looking at, from the laboratory markers was actually really looking at the other immune markers like CD57 marker, which is an NK marker, as well as CD19, which is the B cell development marker, and as well as ANAs, so autonuclear antigens and rheumatoid factor. All of these can tell something of the patient. And if we look at a smaller subset in this cohort that have been tested for CD57, because not all of them actually paid for this test, so we have a small, lower number, you can really see that up to 60% of these patients are suffering in total of a low CD57. And again, we divided them into different kind of immune response. So Borrelia infection only, Borrelia and co-infections, or only other tick-borne co-infections without Borrelia. And then, of course, the most interesting group, the negative serology. Negative serology patient group that didn't show Borrelia serology or other tick-borne infection serology, but they are demonstrating actually a huge proportion in this sample size that they actually have very low CD57. And so generally speaking, okay, I would say not to dismiss negative serology and look at the CD57. It can be a marker of immune fitness or immune dysfunction. So we need to kind of look at that, especially in negative serology patients. But generally speaking, as high as 60%, okay, of these patients suffering from tick-borne infections have a low CD57. And we and others have seen this before. If we look at the ANAs, autonuclear antigens, again, we only had a subset of this cohort, only 22 patients. And we looked at statistically how many of these patients were having a weak positive or a positive ANA. And here we have about, let's say, 26% of the people. So 26% of the individuals suffering from tick-borne infection could actually have a positive ANA work. Us and others has demonstrated this as well in these types of patients. But looking further into the CD19 markers, okay, so CD19 marker, and it's also the CD19 percentage. We had actually a good subset of these patients, so 101 patients, and you can really see that there is within a substantial amount of people, they have abnormal values for the CD19. Some are low, so we have like around 15% of the patients are having a low CD19 marker. We had, okay, one individual or 1% actually, yes, one individual that had a high CD19 marker. But if you look at the CD19 percentages, we're going up as high as 36%, 37%. And take a look also, though, if you look at this negative serology individuals, okay, they are following this trend as well. So 15% of them actually had low CD19 and then, of course, a low CD19 percentage. So it's worthwhile looking at the immune fitness of these individuals, especially if they're seronegative. And if you look at these individuals with rheumatoid factor, which is interesting, we had a large subset amount of patients as well. We can see about 10% of these individuals are suffering or have the rheumatoid factor. Not as significant as the other markers, but still in relation to immune fitness markers. So these, by evaluating the CD57, ANA, rheumatoid factor, and CD19, we kind of get an understanding of what's going on, that these patients' immune system could be at a dysfunction or it's compromised, and we should not dismiss the negative serology individuals. So the key findings of this paper was that this abnormal immune markers, okay, are seen in these negative serological patients. There are constantly a trend of low CD3, CD4, CD8 lymphocytes, IgM abnormalities, and neutrophils. There is significantly abnormal values for CD57, CD19, and transferrin levels. So the clinical implication is that these markers could support the diagnosis of tick-borne infections, but also characterize these individuals. So this is kind of like a trend that you could be looking for and should be looking for, especially if treatment is not working. So we need to kind of correlate this with treatment success or treatment failure or treatment that needs to persist longer time. So I would like to now kind of go to that theme of correlating the pain and biomarkers. And Minha, if you want to step in here and give an intro to this paper.
Absolutely. Well, essentially, this is where I reached out and I said, to my clinician colleague, Professor Jack Lambert, about my worry in terms of the numbers of patients I'd begun to see who were literally slipping through the net. These are patients who had seen their GP, and I'm saying this in a real respectful way, if I may add. They'd seen their GP, they'd gone through different specialties in secondary care, they'd spent a lot of money, in additional care systems as well, and yet they've been told, oh, your bloods are normal, and big inverted commas. And for those of us attending here today, we know that does normal really exist? We're looking at ideally optimal blood results for the patient in front of us. So coming back to the pain side of things, essentially, pain is defined as the International Association for the Study of Pain as an unpleasant sensory and emotional experience. Please let's bear in mind that part, the humane part of this, which is associated with or resembling actual or potential tissue damage. And this is the key for our patients with Lyme and tick-borne co-infections, where we know that from an anatomical perspective, what happens? The Lyme spirochetes go and actually, inhibit the regeneration of collagen. This is just a quick example by fibronectin, and this causes actual tissue damage. We have this on autopsy results. We have this, on histopathological slides. So when you have a patient in pain, you have to ask yourself the question, where is the pain coming from? Is this from bone? Well, technically speaking, talking of T cells, as Leona very kindly mentioned here, Professor Leona said that yes, we have, and so did Kunal, with the CD4 count. CD4 count are your helper cells. The T cells start in the spongy tissue inside the bone marrow. So you ask yourself, and then they move over to the thymus, etc., etc. Where's the pain coming from? Is it from the bone? Is it from the muscle? Is it from the nerves? Is it from the tendon? Is it from the fascia? Is it from what we call the fascial space that holds the lymph? And moving on to the question in terms of, pain relief, well, really, pain relief is a human right. And the neurobiology of pain, we know that there have been some animal studies so far, and this is only as recent as 2020, Lambert et al. Talked about T cells being critical for the resolution of comorbid inflammatory pain. And this was also to do with depression-like behavior. This was published in the Neurobiology of Pain. And we talk about functional pain scoring, where not only did we look at pain overall, we actually looked at pain that will cause bad functioning. So with that, Leona, over to yourself.
Right. Thank you. Okay, Kunal, if you want to start with the results.
Right. So with that introduction, I would like to try to connect that with the data that we are actually seeing. So we ask in these slides, in the interest of time, we are asking 3 different questions. The first one is because we are dealing with pain and because we are dealing with biomarkers, especially in the context of pain, do we see any correlation between the age and gender with the pain rating in our patients? So you can see that in figure A, the age is roughly normally distributed, so that is good enough for us. And in gender, we have more female than male in the study. However, in figure C, when you can see that on the y-axis, we have the age, and on the x-axis, we have the pain rating going from 0, wherein there is no pain, to 12 or 10, where there is high pain. And you can see that the regression line in blue and orange for time points T0 and T2 are pretty much flat, essentially indicating that age is not influencing the pain rating in this study at both time points. And also, when we come to the final figure D, irrespective of the gender that we are seeing, at both the time points, we do not see gender influencing the pain. So in blue, you can see time point T0. In female and in male, the median, which is the dotted line that is crossing the blue and the yellow region, or sorry, the orange region. This is the median, which is the exact same, irrespective of the gender. But we can see that there is a complete shift in the graph from T0 to T2. So for females, the pain rating is towards the higher side at T0, but at T2 it moves left, and the same can be said for the male, which kind of answers the second question, which is in the next slide. So the second question was, do we see a significant difference in pain between T0 and T2? And the answer is yes. So on the leftmost figure in blue, you can see that the patients reported higher pain at T0, and this completely changes at T2, wherein we see a double curve or a curve with two peaks essentially at T2. However, if you look at the median pain change from T0 to T2, so it goes from 7 median pain at T0 to almost 5 at T2. Again, going back to the same understanding of what is the probability of seeing a patient with a certain pain rating at T0 versus T2. For example, if we pick up pain rating 6, the probability of seeing a patient reporting pain rating of 6 or higher at T0 would be 20%, whereas at T2 it would be 60%. So there's a difference in probability also in these patients. However, these are two different things. We have not correlated the pain to the biomarkers, and for this we created the cluster maps to really understand the correlation between the biomarkers and the pain rating. So this is a lot of color and a lot of numbers and a lot of words essentially, but I would like to direct your attention to the dendrograms. So on figure A, you can see the lines that are on the top, and you can see two groups essentially. On the left, there is transferrin saturation percentage, platelets and neutrophils that are correlated amongst themselves, and the blue color indicates values that are low in scale. We come to the second group. The second group is transferrin, pain rating, and CD4. And this is where we see that pain rating is directly related with CD4, and we can see the color combination. And pain rating, if you see, there's a lot of red that you see, which indicates that there are many patients that have reported a higher pain rating, which we've already seen from the previous graph. But these higher pain ratings also correlate with higher CD4 percentage values. And a close second to pain rating is the transferrin. So transferrin and CD4 are closely correlated to pain rating, whereas transferrin saturation, platelets, and neutrophils are negatively correlated to the pain rating. So this is what we see at T0 in the patients. However, at T2, you see that neutrophils, platelets, transferrin are still correlated amongst themselves. However, pain rating is not anymore directly correlated to CD4 or any of the other markers. So you can see that the dendrogram on the top has completely changed, indicating that the relationship that pain rating had with the biomarkers, especially CD4 and transferrin at T2, is not the same at T2. And the reason for this is that you do not see so much red in the pain rating column as you saw in T0. So going to the next slide, I think we have the conclusions there.
Yeah, so Minha, do you just want to wrap this up shortly with the key finding?
Absolutely. Well, the first one, and I remember when we were having the discussion when these findings came through, no significant influence of age or gender on pain ratings. And this throws that whole theory just about out of the window, where if I may say, a menopausal lady of therefore a certain age comes to the clinic and, and is then sort of, it's almost like, oh, well, yeah, the patient's got fibromyalgia, or the patient's got chronic pain, or the patient's not being believed to. The number of times I've seen this in clinic, and I think to myself, this was really significant. I remember when Kunal presented this and I was like, gosh, this is so important. So in other words, listen to the patient, and don't stereotype them, number one. Number two, regarding the notable reduction in pain following antibiotic treatment, just the way if a person has got diabetes, we give them the relevant diabetic medication or appropriate, therapeutics. Surely, the work that, Jack has put together here in offering antibiotic treatments beyond the 2-week so-called, arbitrary period is essential here, because pain is a measure of quality of life and can actually cause a lot of multi-system, premature disability if not looked after or not managed, and invisible impairments. The transferrin. Well, transferrin is a protein of beta globulin, and it binds and transports iron in the blood and serum. And we know from a medical perspective that ferritin is a marker of inflammation. And therefore, let's look at the iron storage and iron recycling cycle. If we are able to lower the inflammation, obviously this is being used using antibiotics beyond the 2-week period, we're actually managing to ideally lower the ferritin. And therefore, the lowered transferrin, the higher number of people with a lowered transferrin, long sentence, in T2, that's at the end of the period of treatment of antibiotics, is a no-brainer, because it shows that we are reducing inflammation, which is a hallmark key feature of tick-borne, infections, so to say. The CD4 count, well, CD4 actually selectively infiltrates the soft meninges and is a marker, especially after peripheral nerve injury. So we know if the Lyme is affecting the tissue, we have problems there. So overall, we're getting some, the story is still evolving here, but let's just see, if you see a patient with these kinds of, findings on their bloods, just keep an open mind is what I would humbly request.
Excellent. Okay, and then for the last manuscript that's almost ready for submission. So the title is an estimation of the prevalence and economic burden in this cohort of chronic Lyme disease. Okay, so we really specifically looked and calculated the prevalence of chronic Lyme disease and also the economic burden. But in doing so, we came up with a chronic Lyme disease patient roadmap modeled. And this modeling actually can help clinicians and scientists actually kind of regulate and control and maybe forecast some trends that they're seeing in these patients. So the blue boxes, okay, blue filled boxes, states that with susceptible individuals, so those people that have been exposed to a tick bite, okay, they might be susceptible to Lyme disease, to chronic Lyme disease, etc. The white boxes are states that these are the infected individuals. The purple arrows denote that these individuals will become chronic Lyme disease patients, and the green box indicates that they have been seen by a healthcare provider. There has been intervention. The black denotes all ending up in the lost to follow-up state or wandering state. And how did we come up with this? We came up with this because of the database and also interviewing different clinicians like Jack, like our colleague Sigrid from her clinic and other clinicians. And this is one of the first of its kind to actually map out and model the roadmap for these chronic Lyme disease patients. Some people will probably disagree with this, but every single box has scientific evidence to justify these boxes and the placement within this model. And some people may call chronic Lyme disease, post-treatment Lyme disease syndrome individuals, or there's even fancier names coming out or proposed. But basically, this is one of its kind that could really help follow these patients, especially in regards to treatment, curing or treatment remission or treatment improvements. And it's interesting because all of these boxes can actually be prevented and with better care and knowledge and actually basically community involvement. So with this model, we actually estimated the prevalence of Ireland, and this is actually anywhere from 0.0024% to a range of 0.1%. And if we look at this prevalence and compare it with US, we are on par, okay? And Ireland is population-wise smaller than the US, but it is definitely on par with actually the expected prevalence of US and other European countries. The economic impact was actually calculated as well in regards to our survey answers and methods of actually calculating this. So the cost per patient in Ireland is around 40,000 or 41,000 euros annually to treat these chronic Lyme disease patients. The total cost for Ireland is roughly, with a prevalence of 0.15%, is 305 million euros. This is huge impact, okay? And then the health economics impact. So we actually calculated this, the low cost of treatment. So of this quality is 0.0319. What this is the quality adjusted life per year. And what we found with all of these assessments and calculations of prevalence economic burden is that we have to really push the importance of consistent diagnosing, proper diagnosing, and consistent treatment so that we can see the economic benefits, okay, with these proper interventions. And that's basically the take-home message for this paper. And it was a great kind of collaboration, and it was interesting to try to come up with these estimates, because we had a lot of assumptions that we needed to make, because there isn't a lot of scientific data coming directly from Ireland. So this is why it was really great to rely on the survey and the questions that Jack had provided for his patients, because we took a lot of assumptions and improved those assumptions based on those survey answers. So I want to wrap up and say that the take-home message for this presentation is that there is a need for accurate diagnosis, timely diagnosis, and effective treatment as actually justified and demonstrated by Jack. He has a great protocol that has a 75% success rate at the moment, and this is just fantastic. There are immense economic benefits if we could manage these chronic Lyme disease patients properly, as we can see with how much it costs through, what was it, the 305 million euros per year, okay? So, and also we need further research and awareness to improve the patient outcomes and reduce economic burden. And this really starts with getting the data in a database, coming together with collaborations and getting the data in a database. So with having said this about getting the data in the database, but we also want to make sure that you have a place that you can publish. So with Jack and I and other collaborators, we are constantly trying to provide a friendly area in which clinicians, researchers, scientists can actually go and put their publications in to be assessed through the peer review process. And one of them is this special issue that we are editors on, and that is the diagnosis and treatment strategies of tick-borne diseases in Frontiers Microbiology. But we also have other satellite journals that if your science or if your manuscript doesn't fit the scope of Frontiers in Microbiology, then there's other satellite journals that will handle the manuscript with utmost professionalism, such as Frontiers in Cellular Infection Microbiology, as well as Frontiers in Public Health and Frontiers in Medicine. So I encourage you to really, if you want a place to submit your work, please go to Frontiers, and we'll be happy to entertain your manuscript. So thank you for your attention, and I'm going to stop sharing screen. And I wanted to mention that we're going to take the time now, and Jillian's going to come in and organize this, of receiving questions and answers, and have a discussion, open discussion about what we just went through. I know it was a lot of information, so thank you for your patience.
Thank you very, very much, Leona and the team. That was amazing information. Very, very interesting. there is, well, there are several questions that have come in already. One here is, does Professor Lambert believe that there are a significant number of patients in Ireland being treated for neurological diseases like Parkinson's, when really it may be chronic Lyme that's causing the neurological symptoms? And a second and third question, I'll ask those afterwards, I think. That's the first one.
Okay, well, very simply, we don't know. We suspect so. I mean, I saw a patient today actually who has been diagnosed with motor neuron disease, but his symptoms started 10 years ago, following a tick bite from his armpit, and he started twitching. And and the neurologists have been seeing him for the last 10 years, and he's got progressive motor neuron disease now. They say it isn't really typical because usually it comes on quickly. You don't have, tingling and twitching for 10 years ahead of time. But nonetheless, I mean, I see case after case of people with neurological disease that followed a tick bite. I've seen it. I see it with long COVID now, people getting neurological problems, having caught COVID and long COVID. So I think timing is important, if so I think I can tell you clinically that I suspect many, many cases of neurological disease, from Parkinson's to motor neuron disease, that I've seen actually clinically improved with antibiotics. But unfortunately, we don't have good diagnostics to prove it. We can't biopsy the brain. We can't isolate Borrelia. We have to use kind of our clinical suspicion, the history, and then response to treatment.
Yeah. And the second question that followed on from that was, chronic Lyme does not appear to be recognized by neurologists in Ireland, unfortunately. Can infectious disease specialists and neurologists work together in Ireland?
But you see, it's not even a matter of none of the infectious disease doctors in Ireland believe in chronic Lyme disease. So how can you, I'm there's 29 infectious disease doctors. I'm one, and versus 28. And they won't, and they don't know the benefits of longer course antibiotics because they've never done it, or they do it behind closed doors and don't tell anybody, and they don't bring patients back for follow-up, so they don't know if patients get better. So it's neurologists discount Lyme, infectious disease doctors discount chronic Lyme, and then rheumatologists discount chronic Lyme in Ireland, is my experience, even when they elicit a history of, oh, you got a tick bite and then you got pains all over, or you get a tick bite, then you get neurological disease. They come up with a diagnose their neurological condition, or they come up with a rheumatological condition, and they say, oh, that tick bite was irrelevant. This is even today, this is my experience.
Terrible. Yeah. Another question that came in quite early: does the treatment plan include any immune modulation, dietary therapy, dental cleanup, etc.?
Right.
Or did it in this
When I
case?
manage patients, like I used to just treat with antibiotics and they improved, but when I stopped the antibiotics, they got worse. So for the chronic Lyme patients, I've really kind of added in a lot of other, I say there's three things going on. There's an infection, there's a damaged immune system, and there's inflammation, and you have to target all three. But so dietary manipulations, lifestyle manipulations, natural anti-inflammatories, natural immune modulators are part of the solution in parallel with the antibiotics.
Yes, you probably wanted to keep it standardized for the study, I can imagine. So, yeah. Do you also use probiotics? Is another doctor's question here.
Yeah, automatically. I mean, your gut is your 80% of your immune cells in your gut. So probiotics, kefir, all those kind of products, and sometimes dietary changes as well. Can help patients tolerate the antibiotics, and also antibiotics. Probiotics are really part of the solution in keeping the microbiome healthy.
Thank you. We've noticed in doing testing that the CD3 plus, when that's low, can indicate a viral load. And you had quite a high CD3 plus. I don't know whether this would be directed toward to Mr. Garg, but do you think that it's possible that these patients had viruses on board as well? Was that tested for?
Some of the viruses were tested in these patients, but we don't have, we had a lot of patients with the missing data, but I think the low CD3 with viruses correlation would be better answered by Meena or Jack.
Okay.
I mean, the hard part in all of this is that if you say that Lyme creates a condition of immunosuppression and, inflammation, autoimmunity, then everybody has endogenous viruses. Everybody has, herpes viruses, zoster viruses in their body, and they're there just waiting to reactivate. And we see all the time patients with Lyme who are immunosuppressed, they get outbreaks of zoster. You see patients with long COVID getting outbreaks of zoster. Just like transplant patients get get zoster. AIDS patients get zoster. So yes, so viruses are there. So everybody has viruses. The issues are viruses driving the low lymphocytes, or are viruses reactivating in response to low lymphocytes that are being driven by these tick-borne infections. We can't really say. But viruses are probably important as well, but very hard to measure.
Absolutely. Yeah. Another question.
Perhaps if I could just second that, absolutely. I see this, perfect storm of almost like a one potato, two potato effect, where, are we looking at pasture? Are we looking at Bouchamp? Are we looking at the germ? Are we looking at the terrain here? And essentially, especially in the patients who seem to potentially have on their on a basic sort of blood test to say that, oh well, your immune system's okay, and this is just looking at the white cell count differential. Hello, the patient may not even have enough of an immune response. They might be immuno-exhausted, so to say. So it just takes another little knock, and here the patient's having trouble. What I do find interesting, if I may just add from a pain perspective, because of course that's where I have a special interest, is that pain is almost a bit like the smoke that's behind a fire, or that comes as a result of a fire. So when a patient tells you that they have pain and, there's no direct mechanical injury or something along those lines, there's something behind this. That there's been a noxious, some sort of stimulation causing the immune system to actually interact, with the nervous system. So I know that's a slight tangent in the way of looking at it, but essentially, let's look at every symptom that comes up as a result of something that's just not right. So we talk about hormesis, and this is when hormesis is not right. Something's going wrong, and we should pay attention to it.
Thank you. One patient is listening here who has had numerous chronic infections, including Borrelia, a very high CD56 plus natural killer cell count, and he's being treated with supplements. And he's wondering whether, because of the emphasis on antibiotics here, that this will be enough, or whether he should, reconsider, I think. I suppose, Professor Lambert, that would be over to you again. Was it just within this study that you felt it was appropriate to focus specifically on antibiotics, or would that always be your go-to?
Well, the reason there's all these herbal protocols in America, Buhner protocol, Cowden protocol. Why did people go for these protocols? It's because these herbal products have anti-infective capacities, right? They do. They so herbal products from artemisinin to cryptolepis to Japanese knotweed, they've got anti-infective capabilities. But and before 1945, that herbalists treated infections, but now that we've got antibiotics, I always say, if I'm treating people who have been unwell for a period of time, herbs are weak antibiotics. It makes more sense to go with the more heavy duty antibiotics, because they're like I said, a lot of antibiotics come from herbal products, So I treat patients, almost all patients, with antibiotics as first line. Now, some patients absolutely can't tolerate antibiotics. So I'm not against using herbs, but there are reasons why, you know, people are allowed a couple of months of antibiotics and improve in that time period. And if they go on a Cowden protocol, it takes them 18 months to improve. It's just my observation. It's a slower process. So they're not mutually exclusive, but, you know, I'm an infectious disease doctor. Antibiotics potentially can kill bacteria, and it's always my first go-to.
Understand. Thank you. One question here in the Q&A, it's very interesting, is I know the NIHR have been approached in the past for studies on Lyme and co. Is there anything in the pipeline to discuss again with them? This attendee is hopeful for new studies, especially now Lyme is getting more bandwidth in the mainstream media. It's a difficult one, isn't it?
It is. I'm not sure if Jack or Gordana has any intentions, or Miha, or it's a
Right.
little difficult for us.
Well, I don't have any involvement with those organizations. All I can tell you is that I have summarily been unsuccessful for applying for any grants related to Lyme tick-borne infections because the traditional organizations that run it just basically veto it from day one because there's no such thing as chronic Lyme. So this is what you run into. So it's, you know, I'm always looking for open-minded organizations who would be willing to look into, you know, kind of novel Lyme research, but I haven't found any governmental institution in the world to date that is open-minded. The only organizations that people are getting funding for doing good Lyme research are the private foundations, mostly in America, Cohen Foundation and some of the Lyme, you know, the well-off kind of Lyme advocacy groups. They've been able to put together, you know, funding mechanisms. So, but it's very difficult. It's very difficult to do Lyme studies even till this day.
Yeah. Well, I mean, go ahead. Sorry, Mina.
That's okay. If I may just add in, having been, I was an NIHR research fellow when I was in Cambridge, and this was in 2008, actually a Walport research fellow as funded by the NIHR. And essentially, going back to what Jack said, the way I see it as a clinician, you know, almost sort of, you know, 15 years down the line now from those days, is that what Jack provides, and this is perhaps even linked to the question on, you know, the use of antibiotics per se versus supplements. Can I just go back to paper number 1 to say that we looked at liver enzymes to get an idea to see if there were any side effects, so to say, you know, in terms of giving the slightly prolonged antibiotic protocol. And we did not see any deterioration, number 1, in the liver enzymes. And that was a very helpful finding. So the safety and efficacy was very important to nail on that. And coming back to the NIHR questions, and therefore the antibiotics that, you know, that are prescribed in Jack, in Professor Lambert's protocol, these are not, you know, what we call sort of high value, very expensive. I mean, they have a cost to them, but they're not going to be, you know, so expensive that they're going to make a lot of money to the, you know, to the companies. And I'm maybe being a little bit political here, but I think from a patient perspective, this is very important. So why would, you know, certain organizations want to fund anything that is not exactly novel, so to say, in terms of what may be seen as a money-making potential? So I'm saying this a little bit in between the lines. Jack, you provide, you know, antibiotics, you know, rationally. You provide them to patients, you know, monitoring them at the same time. And essentially, if it's not going to be the newest, you know, rituximab or MAB for that matter, how can we get, you know, most of these organizations that sadly have pharmaceutical funding behind them to actually take an interest? This is more of an observation and a comment that I have seen being an NIH.
Very important as well, very important comment. But hopefully these 4, go ahead, sorry, Leona, yes.
But at the EU level, they had a call for chronic Lyme disease. Okay, last year, and we absolutely pulled together a cohort with Jack and others, and to address chronic Lyme disease and to look at the pathophysiological mechanisms that Borrelia uses to establish chronic Lyme disease. And we thought that we had a really fantastic, how do I say, fantastic application, because they said it in the call. EU said it in the call, chronic Lyme disease. But what did our reviewer says? Well, there's no data to support chronic Lyme disease.
No.
I'm going, what the hell? I mean, so even though we have top agencies, you know, trying to drive chronic Lyme disease, we have reviewers or editors and reviewers for papers, you know, that have the power to veto or stop, you know, things progressing. But that may sound negative, but we just have to keep trying and trying and trying. Like Jack and I are, you know, doing the co-editing, you know, of special issues of journals. You know, we just keep having to, you know, put in the fight and keep doing and trying to, you know, get funding and do this type of funding that we're doing here, or this type of research that we're doing here, because we could, you know, get it published, and then hopefully, because Jack has long-term antibiotic use. We have demonstrated that, you know, people are tolerating it. We're demonstrating the biomarkers are useful. We're demonstrating the economic burden in these patients, you know. So this is the whole point of, there's ways in getting research, you know, pulled together cost effectively, yes, and out there so that it can be peer reviewed and could be accepted and published. And hopefully that gives us the ammunition, more ammunition to be more kind of competitive in these other calls that could come up with EU or national funding schemes and so forth. But yeah, we still have a battle to go forward in actually attracting research funding in this area.
No, it's fantastic that you've put together these 4 articles, and that's on the back of so much research. Very, very appreciated by everybody here and beyond. I'm mindful of your time because we are getting on to 8:10 already. So we will save all the questions and the comments that have come in, and hopefully be able to answer them a little bit, you know, later, because this isn't the last time we'll have this wonderful roundtable this year. We are having further roundtables with some of the members, certainly of this team, later in the year. And I just want to mention the next one, which is on the 16th of July, so that's not long, with Professor Robert Bransfield, Dr. Rosalie Greenberg, and Dr. Charlotte Mao. I know they're all colleagues of yours, and they're going to be talking about microbes and mental illness, the past, present, and future. So please do join for that. And thank you very, very much again, all of you, for this fantastic webinar that you've given to us. We've learned so much and look forward to reading those articles. We have had questions asking whether the slides will be available. I think, Professor Gilbert, you said that only a little bit later because 2 of the articles haven't yet been fully approved. Is that correct?
Yeah, I would just wait a little bit,
Okay.
just a little bit.
Okay, so
Fingers
Dr.
crossed,
Dr. Kelger, it will come, but it'll just take a little while. But the presentation will go up, so all the slides are visible on that. Thank you, everybody. Lots and lots of accolades coming in. That really was fascinating. Very, very excellent. And look forward to speaking to you all again. And thank you, everybody who's been there. Thank you to all of the audience.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Cheers.
Bye.